All right. So my name is Rebecca Lehman. I'm a pediatric neurologist and have subspecialty training in movement disorders. And so I see a practice that's mixed with general child neurology and pediatric movement specifically. I'm also a member of the medical advisory board for the Tourette Association. I'm sort of here in that capacity today, and I appreciate you guys having us come speak to you about Tourette syndrome. So we're going to talk about the diagnosis and treatment of Tourette syndrome today. And I'm going to give you my disclosures here first. So my financial disclosures, I'm reimbursed by the Tourette Association of America for travel to their medical advisory board meetings and for these lectures through a CDC grant. And also was reimbursed within the last 12 months for travel and participation in an advisory board for TEBA. I am a participant as a PI, sub-I, and rater for a number of trials for different companies, but don't receive direct compensation for those. And the treatments that I'm going to talk about today for Tourette are largely off-label. There are a few exceptions that I've listed here, and I'll try to point those out as we're talking about them as well. I'm going to turn things over for a second here to Angela Sullivan, who's the representative from the Tourette Association of America, to just talk quickly on the next couple of slides and introduce the organization.
Hi, everyone. Thank you so much for joining us this morning. So as Dr. Lehman mentioned, before we get started, just wanted to take a few minutes of your time and share with you some information about the TAA and the program that you're all here for today. As she mentioned, my name is Angela Sullivan, and I'm the Medical Project Specialist at the Tourette Association of America. We're located in New York City. Today's program is being sponsored by our cooperative agreement with the Centers for Disease Control and Prevention. We're currently in our 16th year of partnership, and with their support, we've been able to travel across the US, sponsoring talks such as the one you hear today, presentations on CBIT, which is a behavior therapy used to treat children with TS, and presentations to educators on how to manage Tourette in the classroom. So at the Tourette Association of America, we're dedicated to making life better for all people affected by Tourette syndrome and tic disorders through efforts that raise awareness, advance research and understanding, and provide support. Next slide. So at the Tourette Association, we, through our 3 pillars, awareness, research, and support, we are able to provide our community with many resources. So through social media, public relations, and news placement, as well as our youth ambassadors located across the country, we raise awareness of Tourette syndrome. This is also done through advocacy and lobbying on Capitol Hill for continued funding. By providing grants and fellowships to both young investigators and other professionals, we can advance research and support clinical trials on Tourette syndrome and the discovery of new treatment options. The TAA also manages a network of over 80 chapters and support groups across the country that provide support at the local level. In addition to these groups, programs such as online support groups, webinars, and the biennial conference and in-person presentations, we provide additional support to our constituents. Our partnership with the CDC has also allowed us to create in-print resources such as the ones that I think arrived to your institution at some point. If they haven't, they're on their way there. In addition to the toolkits that you should receive or have access to, we have resources available for other members of the community, including children and families, young adults, and most recently, we created a toolkit for law enforcement. These resources are available on our website in PDF format, and if you feel the need that you're in need of more, or your patients and families need access to these, they can always be mailed to you. And the last thing that I will briefly mention is that this year we have gone completely electronic. Well, we're now virtual, but electronic with our evaluations. So at the end of the presentation, there will be a slide with a QR code. All you have to do is hold your smartphone camera up to it, and the link to the survey will pop up. If you wouldn't mind taking a few minutes to complete that, that would be extremely great. That would be extremely helpful for us. This allows us to report back to the CDC on how these programs are doing and give them a good reason to continue funding these efforts to spread awareness of Tourette syndrome. I will also drop it in the chat, so if anyone has access to that, you can feel free to just click the link there and give us your feedback. We would greatly appreciate it. So Dr. Lehman, that's all for me. Thank you.
All right. And just as a quick preface, one of the reasons we're talking about this and focusing on Tourette is because it is not a rare condition. As you can see on this slide, 1 out of every 100 children has Tourette syndrome or another tic disorder. And right now, about 50% of those individuals are going undiagnosed. And that's why we wanted to kind of share this information, get it out there so that the condition is being recognized quickly and diagnosed appropriately. People are being given accurate information, and providers are on the lookout for some of the comorbid disorders that you can see along with Tourette syndrome as well. So to that end, our objectives for today are to describe the clinical characteristics of tics and specifically to define Tourette disorder or Tourette syndrome, list some of the neuropsychiatric conditions that commonly co-occur with Tourette. We'll talk a little bit about about PANDAS and the related condition PANS, and outline some of the management strategies for Tourette, and talk briefly about the educational accommodations that can sometimes be helpful as well. And I'll end with a few resources that may be helpful for you if you're managing patients with this condition. So we'll start basic here. What are tics? They are movements or vocalizations that have some characteristic features. I put this image on here because sometimes when I say this to kids who are coming from rural South Carolina, they kind of look at me with this like horrified look in their eyes because they're used to pulling this kind of tic off of their pet. And I point out that it is not the same type of tic. This is TIC tic. And so these are movements or vocalizations that are sudden, they're abrupt, they are repetitive and stereotyped. So you're seeing the same, each time a particular movement occurs, it's looking the same every time that it happens. One of the features that helps to differentiate tics from some of the other movement disorders that share some of those features are that in some cases, tics are preceded by a premonitory urge or a kind of warning feeling, if you will. And people describe this in different ways, a tingling feeling, a tight feeling, a pulling, a tickly feeling. I feel like I have something in my eyes feel really dry. And so you can see in this diagram sort of the hotspot areas for where the urges tend to occur, with black being kind of areas that are more frequently affected. And so typically if an urge happens, it happens in the region of where the tic is going to happen. So I get a tight feeling in my shoulder that makes me feel like I have to shrug it to get that feeling to go away temporarily or to get better temporarily. Now, not every tic has a premonitory urge, and they typically aren't reported by really young children. They tend to be reported more after people have had tics for a few years. Other characteristics that you may see, tics are briefly suppressible, so people can hold them in. And for people who have never experienced tics, I give them the analogy of it's like holding in a sneeze. You can do it. You can do it for variable lengths of time, sometimes a few seconds, sometimes a few minutes, probably not a whole lot longer than that. And after a while, that kind of need to sneeze might become overwhelming and make you feel like you just have to do it. And that's how a lot of kids describe this feeling. The tics, even though each individual tic is stereotyped or kind of looks the same every time, the repertoire of tics that someone has can vary over time and often does, with new tics popping up and old tics fading away, some that may last days to months to weeks and others that may last months to years. I do point out to families that tics are not caused by stress, even though sometimes people use the term nervous tics. That's sort of misleading, but they are influenced by stress. And so in someone who has tics, you may see tics happening more in situations of good stress, like excitement or anticipation, bad stress, like being reprimanded or being nervous, and then physical stress as well, like being overtired or ill. Their tics may happen more temporarily. Some people notice that their tics decrease when they're really focusing hard on something like playing the guitar or a math problem. And occasionally, unlike many other movement disorders, you can see tics in sleep. For most patients, they abate during sleep, but and when you do see them, they're usually much milder during sleep than they are during the daytime, but the same movement or vocalization that's happening in the day. So once we've established movement or sound is we can think about them in sort of different ways of grouping them semiologically. So we have tics and complex tics, and we have motor tics and phonic or vocal tics. Those terms are sort of used relatively interchangeably. Some people, for semantics, the term phonic because all of the noises actually represent the use of the vocal cords. So simple refers to kind of brief fragments of movement or sound that don't really have any meaning. So I listed some examples in this chart here. The most common first tic in about 50% of cases is eye blinking. So that's by far the most common one. The complex tics, by contrast, seem to have a purpose, or they seem like something that could be more of a voluntary or purposeful behavior. So these might be things like kind of unusual facial expressions, or more involved gestures, repeating words or echoing words, things of that nature. So I'm going to try to switch over to a clip here of the video, and this may challenge my technical abilities here, but this is a video called I Have Tourette's, but Tourette's Doesn't Have Me. It was put out jointly by the HBO and the Tourette Association of America. At the time was then called the Tourette Syndrome Association, several years ago, and actually won an Emmy back in 2006. A very nice documentary that kind of has children talking about their tic disorders, and is a nice example of several different types of tics just in the first scene here. So we're going to try to switch over to this hopefully successfully here. All right. And give me a shout if you're not seeing what I'm seeing here, but I am seeing the video playing.
See it. We can't hear it, or at least I can't.
Okay. How about now?
Not contagious.
Yep.
Metal.
Yep.
They like come all the time. Coffee. It's there. Why do you have to make fun of it? They just think I'm real crazy.
A person who has Tourette's isn't like a whole another person. Like me. I'm a regular kid.
I'm just going to let this play for a second to show you some examples of some different types of tics that these children are demonstrating.
It feels weird because I'm in control of everything else. Why aren't I in control of that? Why can't I stop myself from doing that?
Well, there it is.
So that's a nice example of a complex tic.
You can't think of anything except holding them back, and you can't think of anything except doing them.
I do that. Like I didn't mean to.
I just feel like kind of funny inside. I say like, why can't I stop doing this? Why can't I stop doing this?
If my hand twitch was really bad, I just hold it down on like a table and just take deep breaths or something and just try to make them stop.
Tics like they're like it's like an itch. Like you have to like scratch it. You just do it. It's like controlling you, and you feel like you have to do it or else something's gonna happen.
All right, and we're going to switch back to the other screen here, hopefully. And we should be back to the, we should be back here, and everyone can still hear me now?
Yes, you're good.
All right. All right, so talking a little bit, once we've sort of established that the movement or sound is tics, we then want to kind of group them into a specific diagnosis, or kind of use what we're seeing to make a specific diagnosis. And the diagnoses are based on the DSM-5. So I'm going to talk a little bit about the different tic disorders specifically. So obviously the focus of today's talk is Tourette disorder or Tourette syndrome. The term disorder was put in DSM-5. It was previously referred to as Tourette syndrome. And there's still some debate back and forth about kind of what the preferred term is. And you may hear me kind of flip-flop back and forth between the two. But the most up-to-date terminology, according to DSM-5, is technically Tourette disorder. So the definition there is that you have to have multiple, so at least 2 motor and at least 1 vocal tic at some point, but not necessarily all at the same time. And they have to have been present for at least a year. So basically looking at from when the first tick appeared as being your starting point to when you are seeing the patient, has it been a year, and have they had at least 2 motor and at least 1 vocal tick? And I point out to parents that that's really all the definition states. It doesn't have anything to do with your prognosis, how severe the ticks are going to be, whether or not you're going to need treatment or any of that. And there are certainly a lot of patients with Tourette disorder who have relatively mild tics and don't require any treatment. And then, of course, as with most of the diagnoses in the DSM-5, the disturbance is not due to something else specific, like a general medical condition or things of that nature. Other tic disorders, if they don't meet those criteria, what would their label be? Persistent or chronic motor tic disorder would be that they have chronic, referring to, again, greater than a year, but only having motor tics. And less commonly, persistent or chronic vocal tic disorder, again, persisting more than a year, but only vocal tics. And that one is a little bit less common than motor. Provisional tic disorder refers to someone who's had any number of tics and any type of tics, but they've been present for less than a year. So more than 4 weeks, but less than 12 months. There used to be a term transient tic disorder, and the problem with that was that it was a retrospective diagnosis. So you could only make the diagnosis once 12 months had already passed, and then you had to look retroactively and say, have the tics gone away? And so it was a challenging diagnosis because you would have to use tic disorder unspecified for the first year until you kind of figured out which group they went into. So when they redid the DSM-5, they switched that to provisional tic disorder, which is a much more user-friendly diagnosis. So it may be that you're seeing someone, 3 months after they develop a tic, their initial diagnosis is provisional tic disorder, but it's important to realize that that diagnosis may change down the road if the tics persist for more than a year. And then there are some other kind of holding categories of other specified tic disorder. That might be someone whose tics were present less than 4 weeks, or maybe they have 1 motor and 1 vocal tic, so don't fit into any of the other categories. Thinking about who gets tics, well, boys get tics about 3 to 4 times more often than girls, but we see them in both genders, and we also see them in all ethnic groups. So they are quite common. So about 1 out of every 4 to 5 children has a tic or tics at some point in childhood. And about 1 out of every 100, as I mentioned on that first slide, have tics that persist for more than a year. Current estimates are that between 3 and 8 out of every 1,000 have tics that meet criteria for a diagnosis of Tourette disorder or Tourette syndrome. One of the questions that parents often want to know is my child going to outgrow this problem? And one of the most common problems I hear when people are coming to me as a consultant is the statement, my pediatrician told me that they were going to outgrow them, and here we are, a year or 2 years or however many years later, and they're still happening. And they're sort of frustrated with that. And, if you're a betting person based on those statistics I just told you, it would be true that the majority of people are going to outgrow them in a brief period of time, less than a year, but there's really no way to predict who's going to do that. And the other piece that parents want to know is sort of how, if they have tics, how can I expect this to progress? And so what we see from this birth cohort study done by Lehman, this was a study of 42 individuals where they recontacted individuals that they had evaluated in their clinic on average about 7 years after their diagnosis. And they asked them to retrospectively recall when they felt like their tics were at their worst. And then they plotted it using different models to see if they could kind of plot when tics were peaking. So what they found was that tics typically start between the ages of 3 and 7, most often at around age 5. And they typically peak in severity at an average of about age 10. So between 8 and 12 tends to be when tics are at their worst for most people. And interestingly, one of the questions I get a lot is that because of puberty? And actually, no, as you can kind of tell from that peak, it's actually preceding puberty a little bit. And so the changes in tics really don't correlate with puberty itself. And then we tend to see a drop-off in tic severity as people are getting into the mid to late teen years and even into the early 20s. So during that time, most people are seeing improvement in their tics. And about 50% of people in this cohort were virtually tic-free by 18. So it's important to note that early tick severity is not necessarily a good predictor of later tick severity. So we're not very good at predicting who's going to outgrow their ticks. And in fact, 20% of the cases that were mild at their initial clinic evaluation in that cohort study went on to have severe ticks, and 90% with severe ticks, marked tick severity at evaluation, had mild to no ticks by 18. The one caveat, though, is that if someone is still having severe tick symptoms as an older teen, that probably does carry a relatively worse prognosis. So take-home point number one, based on that natural history plot that I just showed you, with most patients having onset between 3 and 7, if you get a patient who is under the age of 2 who has tics, think very hard about that diagnosis. Down to age 2, we can sometimes see tics, especially if there's a strong family history or things of that nature. But under age 2, almost always what people are actually referring to is a motor stereotypy, which has some similarities to tics, but in that they're repetitive, coordinated, and stereotyped movements. But they tend to start in a much younger age group, usually late infancy or most often under the age of 3. And the movement itself tends to be very consistent over time without that changing repertoire that we talked about before that's characteristic of tics. What other things might you consider besides stereotypies when you're kind of thinking about the differential for tics, or when someone presents with repetitive movements or sounds? So certainly when I mentioned that eye blinking is one of the most common first tics, eye rolling and eye turning movements are also quite common, and that can sometimes be mistaken for absence seizures. Blinking also often triggers a concern about allergies or vision problems. So often patients will have seen an optometrist or ophthalmologist before seeing me, or be on Claritin and Zyrtec, and nothing's really helping. Facial grimacing can sometimes be mistaken for dystonia. And again, sniffing, which is one of the more common vocal tics with allergies. A number of other movements can also be confused with tics in terms of other involuntary movements, myoclonus, chorea, things like that. But there are specific features of those that semiologically usually allow for the differentiation. One of the other concerns that comes up frequently is, what is the cause of this? And people tend to want an answer to, why did my child develop tics? And often that brings people to an online search, which often brings people to information about PANDAS. So it's a question that tends to come up quite frequently in clinic. So what is PANDAS? It's an acronym. It stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infections. Thank goodness they gave it an acronym. And so this was conceived of by Susan Sweeto and her group back in the 1990s. And what they were trying to do is they were really trying to, for research purposes, see if they could find a subgroup of children that were presenting with OCD and tics who had an autoimmune trigger, and specifically a strep trigger. And this was sort of drawn from the idea that in Sydenham's chorea, which is a different movement disorder, that we actually see that as a post-infectious result of a preceding strep infection, and that as the body is trying to fight the strep infection, it's producing antibodies to fight off the infection that are cross-reactive with the brain nervous system. So that was the idea, was to see if they could differentiate this group. And over time, it's come to be used as more of a clinical criterion, but hasn't necessarily been substantiated with evidence that it is in fact a distinct group. So what are the characteristics that you need according to their criteria? OCD and or tics, a prepubertal onset, although there's some debate about whether there could be later onset, an episodic sawtooth course. So this is a very acute, dramatic onset of OCD and tic symptoms. Some will also argue that you can have an acute or dramatic exacerbation of OCD or tic symptoms in close temporal association with a group A beta hemolytic strep infection. And then also there's an association of other kind of soft neurological signs as well. This has been a very hotly debated topic for almost 20 years now. or over 20 years now, I guess. Most recently, there was a study that was published by a large multi-center study done in Europe called MTICS that was specifically trying to answer some of these questions. Is this really a distinct population? Can we really separate out this group? And the most significant result of that study is that they found no indication for a role of new group A strep exposures in relation to exacerbations of tics. They actually indicated that the co-occurrence of tic exacerbations and recent group A strep exposures was most likely due to chance, because both tics and strep are quite common in the school-age population. There's also sort of an expanded syndrome referred to as PANS, pediatric acute onset neuropsychiatric syndrome, that also comes up in this conversation of, well, maybe it's not strep, maybe there's some other infectious trigger. So again, this idea of an abrupt dramatic onset, but it's very important to note that in the definition of PANS, tics are not part of the definition. So it's an abrupt dramatic onset of OCD or severely restricted food intake. Now, they may have tics as a sort of secondary sign, but it's not part of the definition. So if someone is coming to you with sort of a relatively abrupt onset of tics, regardless of any other data, you can sort of say that they don't meet criteria for PANS because tics are not a core feature of that condition. So what I see a lot is that people conflate the PANDAS criteria with the PANS criteria, which makes things even a little bit more confusing. So take-home point number 2 is that tics tend to stay in a pack with a number of other conditions, and it's important to be aware of those conditions when you are evaluating a patient with tics, so that you're looking for some of those comorbidities actively. So what are those comorbid conditions? So this is a lovely diagram that's actually in some of the packets that Angela was referring to earlier that you should have received or will be receiving. And I think it's a really nice way to depict things for families, so that the tics are what we see here on the surface, kind of the tip of the iceberg, but that a lot of children with tics also have a number of things going on under the surface, many of which may be impacting them more than the tics themselves. So the biggest overlap is ADHD. About 65% of kids with Tourette also have ADHD. The second biggest is with anxiety, with about 40% having something in the anxiety family, social generalized anxiety, OCD. And then we see a number of other overlaps with other conduct issues, sleep issues, learning issues. So these can be pretty far-reaching and have a great impact on their performance at home and at school. So once we've sort of identified kind of the issues that are going on, we've determined that it's tics, we've classified them and given them a solid diagnosis, and we've looked for some of these comorbid issues. What do we do about it? So sometimes what we do is a whole lot of nothing. And that's because not all patients require treatment. So our current treatments are symptomatic treatments. They do not cure tics. They do not change the natural history of tics. So when we think about treating, we really think about treating if the tics are causing physical discomfort, if they're causing social distress or kind of emotional distress where the child is very self-conscious, or if they're causing a significant disturbance in the classroom setting. So a lot of times when you ask the child directly, and it's important to ask the child directly, sometimes the parent is bothered by the tics a lot more than the child is. So it's not that you don't want to solicit the parent's input, and sometimes, you know, kids will minimize their symptoms in clinic, but a lot of times the parent is very worried, maybe worried that my child's going to middle school next year and I'm concerned they're going to be bullied or things like that. Whereas the child themselves is sitting there saying, yeah, I mean, I don't really even notice them most of the time and no one's really commenting on them and they're not really bothering me. So looking at from the child's perspective, you know, are they bothersome? Are they causing impairment? That helps to decide whether you need to do anything about them. One of the questions that comes up a lot when people are trying to avoid pharmacotherapy in particular is, you know, are there dietary or kind of naturalistic things that we could do? Unfortunately, at this point, there's no data to suggest that either elimination diets or dietary supplements are helpful. Finally, in terms of thinking about treating ticks, the important thing is to make sure you're treating the most impairing problem first. And that may or may not be the ticks. So they may come through your door because of the ticks, because ticks are visible or audible and they're noticeable to others. But when you kind of dig and screen for those comorbidities, you may find that actually they're most impaired by something else going on. Sometimes what I'll hear is, well, their ticks are distracting them and that's why they're failing in school. Well, chances are that's not the case. Sometimes ticks can do that, but more often what is actually happening there is that they have comorbid ADHD that's not being treated. And so really assessing, if a child is very distressed by their ticks out of proportion to how severe objectively the ticks seem to be, screen for anxiety. Are they kind of feeling, they have a lot of social anxiety, so they're more aware and attuned and bothered by their ticks socially than maybe they need to be. So assessing for those conditions and treating the thing that's the most impairing first. So I think this is a great cartoon. I think it really captures the essence of ADHD. By the time I think about what I'm going to do, I already did it. And so poor Dennis is there in timeout. And so again, a lot of these children are also dealing with ADHD. And one of the things I probably talk to parents about most often is how we can treat both conditions effectively. Because often by the time children are seeing me, someone has raised a concern that their stimulants are causing their tics and has stopped their stimulant. And so what I typically see at that point is that they're still having tics and now they're failing in school. And so it's important to know that there's very good evidence that tics don't cause stimulants do not cause long-term worsening of tics. And that was actually first determined by a study, this study here, the treatment of ADHD in children with tics, or TACT trial, back in 2002. This trial had 4 arms, about 30-ish kids in each arm, a methylphenidate alone, clonidine alone, methylphenidate and clonidine, and a placebo group. And at the time, the thinking was that the stimulants would worsen the tics, and so they were looking at that and to see if this was a safe treatment. And what they found, so at the top here you have Conners questionnaires, which are the for ADHD, as I'm sure most of you know, and then the Yale Global Tic Severity Scale, which is the most commonly used measure in studies for tic disorders. And so looking here, what you can see in both graphs is that all 3 active treatments actually did better in terms of their ADHD symptoms and in terms of their tics over the course of the 16-week study as compared to placebo. There was a significant difference in terms of the group that was on both treatments did significantly better. So there was a synergistic effect of the methylphenidate and clonidine. But even the folks who were on methylphenidate alone actually had improvement in their tics over the 16-week study. And the percentage of people who had worsening of their tics over that time period was essentially the same statistically in the treatment and placebo groups. So take-home message there, stimulants are safe and effective and should be considered for patients with ADHD, particularly if they have a strong inattention component, because inattention is much more effectively treated with stimulants than with non-stimulants. Take-home point number 6. So this was kind of a more recent development or understanding of, in terms of information that's come to light more recently, is that folks with Tourette disorder or chronic tic disorders are at increased risk of suicide. And so it's really important as part of your screening for those comorbidities to include a suicide assessment about both suicidal thoughts and suicidal behaviors in this population, and to direct them to the appropriate resources if they're expressing those concerns. The odds ratio of folks with Tourette disorder committing or considering or committing suicide is about 3 to 4 times the baseline population. So the odds ratio is about 3 to 4. So a fairly significant increase. And the odds ratio of actually completing suicide is highest in people who have tics that persist into adulthood or have a previous suicide attempt. The odds ratio for that's about 11. So this is a pretty high risk group and definitely worth screening directly. Last year, there were some treatment guidelines published by the American Academy of Neurology, and I'm going to refer to some of those in talking for the rest of the talk about some of the treatment options that are available if you decide that the ticks are impairing and needing treatment. So, one step in the treatment is to enlist the help of your colleagues, both the occupational therapists, physical therapists, and speech language pathologists can all be helpful for addressing different aspects of either the tics themselves or some of the comorbid conditions. And particularly OTs are very well suited for this because they really have an emphasis on activities of daily living and functioning independently in your community and kind of achieving these independent roles and habits and routines. So they can help in a number of different ways. What is quickly becoming a first-line treatment is recommended in most guidelines as a first-line treatment is the comprehensive behavioral intervention in tics, or CBIT. And so there's a study back in May of 2010, the biggest behavioral therapy trial at the time, that looked at this particular behavioral intervention as compared to supportive counseling and psychoeducation about tics. And so the idea behind this loop that happens where you have some situational antecedents or kind of factors that may influence tics, and this kind of uncomfortable urge that we talked about before that may make people want to do the tic in that particular moment, the expression of the tic itself, and then there's kind of relief of that urge. And so this creates a kind of feedback cycle that drives the tic further and further. So the idea is, can we break that cycle? And so the core part of CBIT is really based in habit reversal training. So that's helping the patient to become aware of when their tic is going to happen. So it's doing some self-monitoring and kind of focusing on that premonitory urge or other early signs that it's going to happen. So the CBIT can be done in people without a clear premonitory urge, but it's certainly a little bit easier in folks who can identify that urge. And I will say that a lot of times if you ask someone, do you get a funny feeling in your body before you do a tic, their initial answer is no. And if you say, do you ever try to hold in your tic? And they say yes. And you say, okay, when you hold in your tic, what starts to happen? What do you feel in your body? And then they can usually describe an uncomfortable feeling. That is their urge, but often they're responding to it so quickly that they don't really recognize it. After we've kind of trained them to be aware of their tic happening, we can teach them what's called a competing response, or with younger kids, we'll call it tic blocker. So this is a voluntary behavior that's physically incompatible with the tic. So not just a distraction. If we're trying to treat a head jerking tic, we wouldn't have them squeeze a stress ball because that would be, you could certainly be doing both of those at the same time. But rather, for a head jerking tic, it might be something like kind of gently tensing the sternocleidomastoid muscles and kind of tucking the chin gently. So a position that you can kind of hold, and you can't be doing that and the head jerk at the same time because they both require the use of the same muscles. And so the goal is to disrupt that negative reinforcement cycle, not just to suppress the tic. The other parts of CBIT that are incorporated are relaxation training and also some functional interventions to look at those, the antecedents that may be driving the tics as well. So that initial study that I referred to had 178 children and adolescents, 126 of whom were randomized. And what did they show? So basically, again, the Yale Global Tic Severity Scale, the total tic score, that's the most common outcome in most studies of tic treatments. At week 10 of treatment, they were finding that there was an effect size between the treatment group, which was getting the CBIT therapy, and the supportive therapy or psychoeducation group of 0.68. What does that mean? Well, that effect size is comparable to the effect of risperidone and ziprasidone, some of our stronger anti-tic medications. A very good outcome there. The other thing that was sort of interesting, they did a 6-month naturalistic observation afterward to see, are these responses durable? Do they keep getting benefit after having done this therapy? And the response was quite durable at 3 months and 6 months out. And so by their calculations, they really only needed to treat 3 patients to see an improvement on the clinical global impressions of change. So that's basically the physician's assessment of, is this patient doing better? And so a number needed to treat of 3 with an absolute risk reduction of 34%. So one of the challenges with CBIT is that it is not always widely available in communities. Often there may not be providers locally, or it may be difficult to get in with them for insurance reasons or other reasons, or patients try it and feel too frustrated with the therapy. Family doesn't have transportation. All sorts of barriers can happen there. So for some patients, either CBIT's not an option or was tried and was not successful, and then we kind of look at the pharmacotherapy options as well. Although they're not FDA approved, one of the first line treatment options is often the alpha-2 agonists. According to the AAN guidelines, clonidine probably and guanfacine possibly are beneficial for tics. And there is some suggestion with subgroup analyses in many of the studies that patients who have comorbid ADHD and tics may actually have a little bit better benefit in terms of their tics from the alpha-2 agonists than those who do not have comorbid ADHD. So what are some of the issues with these medications? The most common side effects are definitely sedation, and dizziness can be quite common as well, related to hypotension. And with guanfacine XR, which goes by the brand name Intuniv, there's also some risk of QT prolongation. So when you're counseling patients about these, obviously counseling about the side effects, monitoring blood pressure and pulse at your visits, and if they're on guanfacine XR and they have either a history of cardiac conditions or they're on other QTC prolonging agents, or there's a family history of long QTC syndrome, that would be worth monitoring their QTC intervals with EKGs. Also important to let patients know not to stop these medications suddenly, because doing so can lead to rebound hypertension. If the alpha-2 agonists are not effective, then often the next tier up of medications would be the D2 antagonists. So these are the neuroleptic or antipsychotic medications that are blocking the dopamine 2 receptors, both the atypical and typical antipsychotics. So what are some of those? I've listed them here. The ones shown in red are the ones that have FDA indications for the treatment of Tourette. And I've listed some initial and kind of dose ranges, but the general principle with these is start low, increase slowly, and use the lowest doses possible for the shortest time possible. Some general principles when prescribing these, there's insufficient evidence to say that one is better than another. There really haven't been a lot of head-to-head studies with these different medications. There have been some, but they're kind of few and far between, many of the newer agents, there haven't been any between the newer atypicals. It's important to note that the atypical antipsychotics are not inherently safer than typical antipsychotics. So a lot of people tend toward those thinking, oh, they're lower risk, and that's not actually the case. And so it is important to reevaluate the need for treatment on an ongoing basis. So what are some of the safety issues that we do see with these medications? The one that people worry most about would be tardive dyskinesia, though it's quite rare. It is basically a repetitive, typically a mouth, oral buccolingual kind of lip smacking or chewing movement that's sort of continuous. And of course, the concern here is that typically if you stop the offending agent, the movement resolves within weeks to months, but in some cases can be permanent. Now, it's a very rare complication and tends to be associated with higher doses and longer periods of use. Again, another reason to keep the doses as low as possible and to use these medicines sparingly. Much more commonly, though, we do see weight gain and somnolence as a common side effect of many of these medications. They can also have effects on the metabolic profile in terms of cholesterol, blood sugars, affect prolactin levels, and cause QTC prolongation. Particularly the most implicated for that being ziprasidone. There are some very nice evidence-based protocols for monitoring the side effects, and I put the link in here for a website that has some very nice graphs that can be included in charts or kind of tables where you can kind of check off to make sure that you're staying on track with the appropriate screening if patients are on these medications. It is important to obtain an EKG before and after starting both pimozide and ziprasidone. or if they're on any medications that prolong the QTC interval along with these medications. And then finally, it's important to taper off of these medications. Stopping them abruptly can be dangerous, but can also lead to withdrawal dyskinesias, which look more like a kind of high amplitude chorea that can occur if they're stopped suddenly. So this is an example of that monitoring graph that I was referring to on the previous screen. So for tracking their height, their weight, their BMI, now many of these are incorporated into EMRs anyway at this point, but also making sure that there's been screening of the appropriate laboratory studies depending on what medication they're on. So what are some of the other players we think about in terms of medications? Benzodiazepines are sometimes used in the treatment of tics, typically as a short-term strategy for bridging someone to a longer-term therapy. So someone who presents to the emergency room maybe with a really violent or self-injurious tic might be a good candidate for that, but typically not a long-term treatment. Some of the substituted benzamides, sulfuride and thiopuride are not available in the US. Metoclopramide is rarely used for tics, but can be have an anti-tic effect. And then tetrabenazine, which I'll talk a little bit more about in one of the later slides, and botulinum toxin. So talking about botulinum toxin first, it's most helpful for dystonic tics, in other words, tics that involve kind of a sustained twisting or turning movements, self-injurious tics like very forceful head flinging, and can be used for vocal tics, although typically those injections would need to be done by someone like an ENT or something of that nature. There is some risk there in terms of hypophonia or kind of softness of the voice and other issues. The effects of Botox are transient, so it typically lasts about 3 months. That's how long the toxin is active. Sometimes the benefits can be a little bit more sustained than that, but can be a good option, particularly, as I mentioned, for the self-injurious tics. The head flinging and things of that nature can cause some serious injuries in some cases, orthopedic injuries. There are some case reports of myelopathies and vertebral artery dissection. So if there's concern that there may be that level of danger, then certainly can be a great option. There's more limited evidence for some of the medications listed here, and some of them are being actively researched. Certainly cannabinoids are of great interest right now for a variety of illnesses, and there are several studies looking at those for Tourette as well. Topiramate is, there have been some small studies of topiramate that may have a moderate anti-tic effect, and according to the AAO guidelines, suggest it's possibly effective and should be considered in folks with mild but impairing tics that maybe have not responded to an alpha-2 agonist. I find it really helpful in the folks who have kind of mild tics but are also already where I'm concerned about exacerbating their weight gain by adding in a neuroleptic agent. There are a number of experimental therapies that have been looked at for Tourette or are currently under investigation. I've listed some of those that are kind of have been either ineffective or discontinued studies here on the left. It's worth noting that the VMAT inhibitors, so I mentioned tetrabenazine earlier, which has an orphan drug designation for Tourette, but some of its related compounds, valbenazine and deutetrabenazine, which is actually a deuterated form of the tetrabenazine drug, both failed to reach their endpoints in recent studies. So it's unclear whether they'll be continuing to roll out studies for those agents. There's a current study that's underway looking at ecopipam, which is sort of interest in the community because it is a first-in-class drug. So it is a D1 dopamine receptor antagonist, whereas all of the other medications that we were just talking about were D2 receptor antagonists. So that's of interest, and the studies are underway for that one. And as I mentioned, there are several studies going on looking at different cannabis-related and cannabinoid compounds. D-cycloserine, which actually stimulates the endogenous cannabinoid receptors, and as well as some studies of non-pharmacologic agents, an oral appliance, and deep brain stimulation, which I'll mention momentarily. So I'm not going through this graphic in detail, but it's a kind of nice, colorful depiction of where all of these different agents are targeting it at the synapse. And you can see that we're kind of hitting this from lots of different sides, and that the treatments we've talked about are all kind of coming at this from different directions. I mentioned that there's been some interest in an oral orthotic for Tourette. So this was actually brought about by two dentists who recognized in their population that if they propped their patients' jaws at a certain distance that was individual specific, their tics seemed to quiet. And they published this information, and it had a lot of interest in the community because obviously there are a lot of people who are have either not had success with medications or experiencing side effects or just want to avoid medications. There are several theories about why this might work. The dentists who initially published the work postulated that maybe there was some kind of nociceptive input that was happening at a kind of subconscious level, so that the patient wasn't aware that they were getting stimulation of the trigeminal nerve pain pathways, but that they were getting this kind of constant noxious feedback. And that one is probably the most disputed of the theories. One of the other theories is that maybe it's sort of a sensory trick. In dystonia, which is a different movement disorder, we sometimes see that patients can find a particular gesture or movement or posture that quiets their dystonia. For example, if they have a neck dystonia, sometimes just kind of lightly touching one side of their face will help to correct that. And the third theory, which has probably garnered the most support, is that actually propping the jaws at that distance opens up the airway and reduces sympathetic output. And so that's probably the one that is sounding most likely at this point, but remains to be proven. And so there is a study that's going to look at the changes in the EKG in association with changes in the tics as well, to see if we're seeing signs of sympathetic changes. Finally, deep brain stimulation. Obviously, this is a much more invasive treatment for Tourette, so is not something that would be considered lightly. We're really talking here about folks who have clearly been diagnosed with Tourette, where they're kind of having moderate to severe, at least moderate, but usually more severe tics. And so according to this guideline of who to consider, a Yale Global Tic Severity Score of 35 is going to place you in a relatively severe category. That the tics are their primary cause of their disability, so they're not unable to work because they're depressed or having issues because of other comorbid conditions. And that they've been refractory to both CBIT as well as classes of trials of different classes of medications. And they outline a number of other recommended guidelines as well. They used to say kind of, the original publication talked about only considering DBS for adult patients, in their 20s and beyond. They removed that criterion, and there's some debate over when the most appropriate timing for this is, because obviously we don't want to be treating patients very young if it's a condition they may outgrow, but that's sort of counterbalanced by safety concerns and social concerns in the younger age group for folks who have extremely severe tics. When we do DBS, where do we put the leads? Well, that's up for debate as well, and so this is still considered an experimental therapy. A number of different targets or a number of different sites have been targeted in different studies. Probably the most frequently used right now is the centromedian nucleus of the thalamus, but the best target is still up for debate, and so that's something that a number of different groups are looking at. Dr. Oken at the University of Florida maintains an international deep brain stimulation registry and database, and that's trying to help kind of collate all of the information that from these surgeries that are being done all over the world, because each center individually does very few. They're trying to pull all of the information about complications, outcomes, and patient demographics together to get a better sense of what are the good targets, who are the best candidates, what are the outcomes that we can predict for people. So as pediatricians, we're often looking at children and how they're interfacing with the educational system and how their tics are affecting them in the classroom, or some of their comorbid conditions are affecting them in the classroom. And so a couple of tips there. One is that many children, certainly not all, but many benefit from having some type of educational accommodations related to their diagnoses, either a 504 plan or an individualized educational plan. And as I point out here, those are governed under different laws and have slightly different safeguards, review processes, etc. So with the IEPs, the initial evaluation has to be completed within 60 days of obtaining parental consent to evaluate. So it's really important to remind parents to request the consent form, to sign the consent form when it's given to them, because that really kicks off the process. And then the team has another 30 days to hold a meeting that the parent is invited to discuss the results and to determine eligibility and discuss what plan is going to be put in place. Higher education is also important to note that these accommodations don't necessarily stop at high school. If a high school age student is going to require accommodations for college entrance exams like SATs or ACTs, they are going to need additional documentation, so they need a plan in place with their school, a 504 or IEP, and then they'll need additional documentation ahead of time, so it's important to make them aware of that, so it's not a last minute thing. And also important to encourage the older students who are maybe transitioning to college to connect with the Office of Student Disability Services, or whatever the equivalent title is at their college. The ADA does require post-secondary institutions to make reasonable accommodations and modifications for students with disabilities to provide equal access to their courses. So, so it's important to let them know that those resources are likely available to them at the college level as well. Some other specific considerations in young adults, making sure to screen for substance misuse. Sometimes people are trying to self-treat their tics or other comorbidities with substances. Sometimes impulsive behaviors are leading to substance misuse for other reasons, so important to screen for that. And then also counseling and helping to negotiate some of the age-specific challenges of transitioning to the workplace, obtaining housing, managing tics on in airplanes or other public places like movie theaters, and dating. So some of the resources that may help you as you're talking to patients about these issues. Angela had mentioned at the beginning of the talk some of the resources available through the Tourette Association, and some of these I think you've received at your institution, but a number of great resources and toolkits there. This website, the CPRI Break Shop, is I find very helpful, particularly for patients with comorbid rage attacks or issues with kind of rage outbursts. But they have, it's a nice website that has little video modules, really kind of geared toward the middle school age boy set, which is certainly the peak population by epidemiology and the natural history of condition. That they have modules in there on that sort of follow the CBIT type framework for tics. They have modules on managing anxiety and on managing a self-management toolbox for helping folks manage rage. So one that I find very useful. There's also the Tic Helper program, and this is designed to help make CBIT more accessible to people. It was designed by psychologists, some of whom were participants in the original CBIT trials, and is a subscription-based online CBIT program. It's about $150 for 8 weeks of access to the program, and then there's an option to extend at $10 a month after that. And I've found this to be useful for some of my patients who live in more outlying areas and really don't have access to a therapist. And so that can be a good option if they want to explore the behavioral health path but don't have a provider available. So that brings me to the end of my talk. I'm happy to answer questions. I know we're kind of running a little short on time. I'm happy to answer questions either now or by email. And Angela can certainly share my email with you. And just as a reminder, if you can scan this QRS code and complete the survey, it's really quick and it very much does help the TAA get the funding support from the CDC to help keep these programs possible. Thank you so much for joining us today and for having us speak with you.
If anyone has any questions, I guess you can just type them into the chat. I don't know if you can unmute yourself. We'll give it another minute, and if not, thank you again. As we've both said, please take just a few moments to complete the survey. It'd be really, really helpful for us. We hope this was effective and useful for you. If you are in need of any additional resources for patients, providers, please feel free to reach out to me. I'm happy to mail them to you. And again, they are accessible via PDF on the website.
I do have a, this is Dr. Mark. I did my residency at MUSC from like 2012, 2015. So I think you were there around that time.
Yeah, I think yep.
Okay, yeah, I was still just as bald then as I am now. So anyway, I'm a pediatric palliative care doctor, and so one thing that my partner when I arrived taught me about was teaching kids and adults self-hypnosis, and so he's much more experienced than I am, but he's been treating a lot of young kids who have tics with or teaching them self-hypnosis for their tics, and seems to have a lot of success with it. And I don't know if you have any thoughts on that, or if that just kind of like falls along the cognitive behavioral pathway of how that's effective.
I'm sorry, I think you're cutting out just a little bit on me. So say again what he's been treating them with.
Self-hypnosis.
Well, you know, I don't know that there's a lot of data for it. You know, I would have to look. I'm not familiar with any studies specifically looking at that for tics. It's one of those things that if someone came to me and asked me about that, I'd say two things. I'd say, one, let me do a lit search and see if there's any data out there. But two, you know, it's probably a relatively low harm intervention. Not to say it's no harm, but probably a relatively low harm intervention. So if someone wanted to try it, you know, I get that question a lot. Magnesium, for example. As I mentioned, there's no evidence to support dietary interventions, but there's a lot of anecdotal stuff out there on the internet about magnesium specifically. And so a lot of times I'll have families say, well, can I just continue the magnesium? I'm like, well, as long as they're not having diarrhea, sure. You know, so it's one of those that it's kind of a low harm thing. And if parents are finding it helpful, but I don't have any experience using that in my population.
Thank you.
Yeah, absolutely. Thanks for joining. All right, and if there are any other questions, like I said, I'd be happy to answer them by email if that would be easier. I'll have Angela pass my email along to Angie Tufts, or actually she has it already in fact, and she's welcome to share that with you. Thanks so much for your time.
Thank you, everyone.
Thank you.
Okay, thank you.
All right.
Bye-bye.
Enjoy the day.
You too.